Welcome to Care of the High-Risk Newborn, Part 3. This section will address feeding issues, eye issues, as well as neonatal sepsis. So as mentioned in video lecture 1, infants are vulnerable to failure to thrive because they have problems eating. You would think that it's normal for this baby to want to eat, but they have to learn. It is normal, it is natural, but they still need to learn. Breastfeeding is normal and natural, but both the mother and the baby need to learn how to do it. So when we're dealing with a preterm infant, they have weak muscles. They tire very easily. They don't have the reflex to suck and swallow until somewhere between the 33rd and 34th week of gestation. So oral feeding is learned and practiced. And what you'll find happening in the NICUs is occupational therapy or speech therapy will come around and they work with these babies to teach them how to eat. And they will teach you how to be able to feed them because it takes a while to do so. In addition, if a baby is born and they have some type of a physiologic problem that's acute or in the long run it becomes a chronic problem, then feeding is going to be delayed. Some babies may have an aversion to having anything in their mouth, especially if they've been intubated because they've had this endotracheal tube in place for a long time, or we may have been putting down gavage tubes and they just are tired of us messing with their mouth and they don't want to have anything to do with feeding. In addition, the parents haven't had any experience with feeding the newborn. So that can result in failure to thrive. If the baby is not able to nipple feed, which is the same as bottle feeding, then we're going to do either a gavage feed, an NG feed, an NJ feed, or some babies will end up with a gastrostomy. So when we're going to do a gavage or an NG feeding, you need to check the residuals. And the standard rule of thumb is a normal residual should be less than half of the volume of the previous feeding. So if the kid took 20 mLs in the previous feeding and now it's time to feed again and you're sucking back 15 mLs, you're going to give that 15 mLs back to the baby and you're going to hold the feed and let the physician know, because we might need to back off on the feeding. Maybe we advance the baby too fast, or the baby may be developing what we call necrotizing enterocolitis. So in which case you need to assess that abdomen. Is it more distended than it was with the previous feed? Measure the abdomen. Does this baby have bowel sounds? What else might be going on? And it may not have anything to do with the gut. The baby may actually have sepsis or something else. So you have to be very careful when we advance these babies' feeding. The sources of nutrition, of course, breast is best. And what the mother will start doing as soon as the baby is born, if the baby can't breastfeed directly, then she's going to be pumping the milk. And we have manual pumping and we have electric breast pumps. And we save the milk and we give it to this baby as soon as the baby is able to eat. If the mom decides not to breastfeed, then we have a variety of formulas. And so if you recall from the very first week of pediatrics, we have a lot of different formulas that have more calories per ounce if needed, so that we're getting that more bang for the buck. The baby only has to take 1 ounce, but they're getting 30 calories instead of the typical 19 or 20. We also have additives. So for a baby that's getting formula, we might add those medium chain triglycerides to increase the calories. Or for breast milk, we have human milk fortifier, and we'll just dump that in to make sure that there is adequate calories in the milk. Some babies that are not able to do any kind of nutrition orally or by the enteral route will be started on TPN and lipids. The next problem we're going to talk about is called retinopathy of prematurity, and it's abbreviated ROP. We don't know exactly what causes it, other than when we give babies too much oxygen. It can happen. They don't know the exact mechanism. But what ends up happening is the vessels in the retina overgrow. And as a result, the vessels end up vasoconstricting and they die off. And then there's scarring on the back of the retina, and the retina can completely detach. eventually it can cause blindness. We know about this now, and as a result, we're going to have an ophthalmologist come in and examine the baby. They treat it with cryotherapy and laser therapy, and then later on the baby may end up needing corrective lenses. And this is how they do the exam. So this is a huge magnifying glass, and we put drops in the baby's eyes so that the pupil stays open, and they're going to quickly examine the eyes, and then they'll plot it on a graph similar to what's on the left side. And then the last part is neonatal infection and sepsis. All babies are at risk for this. If we don't wash our hands, or if the guests don't wash their hands, or we drop something on the floor and we pick it up and we end up using it, we are introducing bacteria to this baby that they may not have an adequate immune response to fight. Some of the other factors can be if ruptured membranes are prolonged. We like to have these babies delivered within 24 hours of the rupturing membranes. If the mother develops a temperature while she's in labor, that increases the risk that this baby is also going to have infection and may develop sepsis. So how do we find out if this baby has it? There we go. Behavior, behavior, behavior. The baby isn't doing what we expect the baby to do. And this can be a preterm baby, and it can be a term baby, or it can be a post-term baby. They feed poorly, they have bradyapnea spells, or in the instance of a preterm baby, they do not respond even to the ventilator as they should. Remember, they don't get fever, so you can't rely on the baby's temperature. In fact, they may be hypothermic, they may be hypoglycemic. We treat neonatal sepsis with antibiotics. Some may be put in isolation, but usually not. You'll be sending off blood cultures, urine cultures. They may do a spinal tap. So the best thing we can do is prevent it. Screen the visitors. We do not allow young children to come into the NICU. Hand washing. And when parents are coming into the NICU for the first time, you as the nurse need to introduce them to the protocol of how they need to scrub their hands, dry their hands, nothing below the elbow, no watches, no jewelry, being very careful about what they wear. We do not use artificial nails. We aren't even wearing lab coats in the NICUs anymore. And make sure that you, as the nurse, are cleaning off all of the equipment as you're going from newborn to newborn. So if you have a stethoscope and they don't have a dedicated stethoscope for each baby, then you need to make sure that you are using alcohol between each baby. And this ends the lecture on care of the newborn related to sepsis, retinopathy of prematurity, and feeding issues.